Welcome back to the Deep Dive. We're here to turn your sources into high-yield knowledge, and today we're tackling something quite a few people experience: hyperhidrosis.
Yeah, excessive sweating.
Exactly. We've got revision material here, perfect if you're prepping for, say, the MSRA, or honestly, if you just want to get a proper handle on this condition. Our plan is to break it all down, pull out the really crucial stuff, and, make it stick.
That's the idea. We'll focus right in on hyperhidrosis, what it actually is, the why behind it, how it presents, and importantly, the management side based on clinical guidance. Think of it as your focused audio revision.
Okay, let's get into it. We'll cover the definition, causes, risk factors, the pathophysiology, how it works, what else might look similar.
Differentials, yeah.
Right. Then epidemiology, clinical features, how to investigate, management, prognosis, and any complications. Ready to dive in.
Let's do it. So first off, what actually is hyperhidrosis?
The definition.
Simply put, it's sweating more than your body physiologically needs to control its temperature. It often hits specific spots: palms, soles, underarms, face, those areas.
And it's more than just, feeling a bit clammy. This can properly impact someone's life, can it? Cause real distress, make people avoid social stuff.
Absolutely. It can have a huge impact on quality of life. And it's generally broken down into types. First, there's primary focal hyperhidrosis.
Okay.
This hits those specific areas: axillae, palms, soles, maybe the scalp. But there's no underlying medical reason we can pinpoint, and it often kicks off early, like childhood or adolescence.
No obvious cause. Starts young. Got it.
Then secondary focal hyperhidrosis. Still specific areas, but this time it is caused by some other underlying condition.
Ah, okay. Secondary means there's a reason.
Exactly. And the third is generalized hyperhidrosis. This affects the whole body, and it's usually linked to systemic medical conditions or maybe drug side effects.
Right. That primary versus secondary split seems fundamental. Focal versus generalized, too.
Definitely. That distinction really guides everything. So, quick scenario for you, thinking MSRA style. A 15-year-old comes in, sweaty palms and feet since they were maybe 10, no other health problems at all. What type are you leaning towards?
Okay. 15, started at 10, just palms and feet, otherwise well.
Oh.
That sounds pretty classic for primary focal hyperhidrosis, right?
Spot on. The age, the location, lack of other issues, point straight there. Okay, so moving on. Etiology. Why does it happen?
The causes.
Well, like we just said, it boils down to primary, which is idiopathic, meaning we don't really know the exact trigger.
Right, no clear cause.
Or is secondary, where there is an identifiable cause. Primary often has a family link, suggesting genetics play a part. Seems like an issue with the sweat glands just being, well, overactive.
Inherited, maybe.
Potentially, yeah. Secondary, though, that's a direct result of something else. Could be an underlying condition or a side effect of medication.
And what sort of things cause secondary?
For the generalized type whole body sweating, you think about things like pregnancy, anxiety. Certain drugs are common culprits, like some antidepressants, propranolol.
Okay.
Infections, sometimes malignancy, heart or respiratory failure, too.
Wow, quite a range.
Yeah. And for secondary focal sweating, just one area, the causes are often more localized. Things like cerebrovascular disease, neuropathies, diabetes complications, intrathoracic growths, mesothelioma is even mentioned as a rare one.
Just mesothelioma, wow.
Yeah, or gustatory sweating, sweating when you eat, sometimes linked to nerve damage, compensatory sweating after surgery or nerve injury, even rarer things like a cervical rib or Raynaud's.
So the same symptom, sweating too much, can point to really different things depending on the pattern and the context.
Precisely, which leads nicely into risk factors. What puts you at higher risk?
Well, following from the causes, I guess family history for primary?
Yep, that genetic link again.
And then for secondary, having one of those conditions or being on those specific medications.
Exactly. Pretty straightforward, but key to keep in mind.
Okay, let's get technical. Pathophysiology. What's actually happening inside the body?
Fundamentally, it's down to overactivity of the eccrine sweat glands. They're just producing too much sweat. Right,
glands working overtime.
In primary hyperhidrosis, while we say idiopathic, the mechanism seems to involve some sort of dysfunction in the autonomic nervous system.
The body's automatic controls.
Exactly. Controls heart rate, digestion, and sweating. In primary, it seems like the system is sending out sweat now. Signals way too often, even when there's no need for cooling.
Like a faulty thermostat stuck on high.
That's a great analogy, actually. Yes. And for secondary hyperhidrosis, it's the underlying condition or the drug that's directly messing with the sweat glands or those autonomic signals.
Okay, so either the control system itself is glitchy primary or something else is interfering with it secondary. That clarifies it nicely.
Now, because sweating can be a symptom of lots of things, what else might you consider? Differential diagnoses?
What could it be mistaken for?
Well, you'd need to rule out things like fever from an infection, thyroid problems, hyperthyroidism especially.
Overactive thyroid.
Yes,
Wow.
menopause is a big one with hot flushes, other infections, and definitely medication side effects. These often cause generalized sweating and need excluding, particularly if you suspect a secondary cause.
Makes sense. So how common is this? Epidemiology.
It's actually more prevalent than you might think. Figures vary, but maybe around 1% to 3% of the UK population, for example.
1 to 3%. Okay.
It affects all sorts of people, any age, any gender. But that primary type, remember, typically shows up earlier. Average onset is somewhere between, say, 14 and 25 years old.
Right. Often starts in teens or early 20s.
Mm-hmm.
Okay. Clinical features. What do you actually see? What does the patient report?
The absolute key is excessive sweating that's not linked to heat or exercise. And it usually hits those typical spots: palms, soles, underarms, face.
And you mentioned it can be constant or come in waves and often symmetrical for primary.
Yes, continuous or episodic and often symmetrical, but this is where you really start thinking primary versus secondary again.
Okay, the clues.
You should suspect an underlying cause if the sweating is generalized, so all over.
Right.
If it happens during sleep, those classic night sweats, that's a big red flag for secondary issues like infections or malignancy.
Night sweats, investigate. Got it.
Also, if there are other systemic symptoms, fever, losing weight without trying, no appetite, palpitations.
Okay, other things going on?
Exactly. Or if they're taking a drug known to cause sweating. And a really important one. If the sweating is unilateral, one side only, or clearly asymmetrical, that often points towards neurological causes, maybe tumors, something localized.
So symmetrical, stops during sleep, leans primary. Asymmetrical, happens during sleep, generalized. Other symptoms, think secondary. That's a useful rule of thumb.
A very good rule of thumb. And always worth asking about anxiety, as it doesn't cause it but can definitely make the sweating worse.
Right.
And there are actually formal diagnostic criteria for primary focal hyperhidrosis. You need that excessive sweating in the typical spot.
Palms, soles, etc.
Yes. Lasting at least 6 months with no apparent secondary cause. Plus, you need at least 2 of these specific features: bilateral and fairly symmetrical sweating.
Both sides.
It impairs their daily life, happens frequently, at least once a week, started before age 25, positive family history, and this is key: the sweating stops during sleep.
That stopping during sleep point, plus the age of onset, really stands out for diagnosing primary. Definitely exam fodder there.
Absolutely. So let's try another quick scenario. A 35-year-old starts getting generalized sweating, but only at night, and they've lost a bit of weight unintentionally. Based on what we just said, where's your focus for investigation?
Okay, 35, so older onset, generalized. Night sweats.
Right.
Weight loss. That screams secondary cause investigation, right? Definitely not primary focal based on those criteria. You'd be thinking infection, malignancy, something systemic.
Exactly. Your focus is finding that underlying cause. Which brings us to investigations. How do we check things out?
Well, you said diagnosis is mainly clinical, based on history.
For primary, yes, often. Investigations really come into play when you suspect secondary hyperhidrosis. You're testing to find that underlying cause.
So not routine tests for everyone.
No, definitely not. The tests depend entirely on the clinical picture. You might do bloods like a full blood count, ESR, CRP for inflammation, maybe kidney and liver function, glucose for diabetes, thyroid tests.
TFTs?
Yes, TFTs, maybe a chest x-ray, HIV test if appropriate. It's all guided by the history and examination findings suggesting a particular secondary cause.
Tailor testing. Got it.
Okay.
The big one. Management.
Yeah.
What can we actually do?
It really hinges on the type. Is it primary or secondary, focal or generalized?
Right.
For generalized hyperhidrosis, the #1 goal is find and treat the underlying cause. That usually means referral to a specialist.
Makes sense. Treat the disease, not just the symptom.
Exactly. For primary focal hyperhidrosis, though, it's usually a stepwise approach. Start with general advice.
Like that.
Avoiding triggers, maybe spicy food, caffeine, heat. Using strong antiperspirants. The aluminum chloride ones are key here. Changing clothes often. Using absorbent pads, perhaps.
Practical stuff first. Then what if that's not enough?
First-line medical treatment is typically topical aluminum chloride. A 20% solution is often used, applied to dry skin at night. Sometimes an oral medication like propantholine bromide might be considered too.
Okay, topical first.
If that doesn't cut it or the patient can't tolerate it, it can be irritating, then referral to a dermatologist is the next step.
And what can the dermatologist offer? More options.
Yes, several more. Non-surgical things include, well, optimizing those topical treatments, maybe different formulations. Then there's iontophoresis.
Oh, hyperthyroidism.
Yeah, it uses a mild electrical current passed through water, usually for hands or feet. It interferes with sweat production. There's a version using glycopyrronium bromide solution with it too, often in secondary care.
Okay, electricity. What else?
Botulinum toxin injections. Botox.
Ah, Botox for sweating.
Yep. It's specifically licensed for severe underarm axillary hyperhidrosis. Works really well for many people. Blocks the nerve signals to the glands locally. Lasts several months usually.
Right. Any surgical options?
Yes, usually reserved for really severe cases where other things haven't worked. There's sympathectomy, endoscopic transthoracic sympathectomy, or ETS, that's cutting or clamping the sympathetic nerves.
Sounds quite major.
It is, and can have side effects like compensatory sweating elsewhere, so it's a big decision. Other options include suction curettage, basically removing the sweat glands, often in the armpits. Laser treatment is sometimes used. And there's a procedure called miragery, which uses electromagnetic energy to destroy the glands. Again, usually for underarms.
Oh, quite the toolkit, from creams right up to nerve surgery.
Yeah.
And you mentioned psychological support, too.
Definitely. Addressing the anxiety and impact on confidence with things like CBT is really important, alongside the physical treatments. Treatment choice depends on severity, location, patient preference, what's worked before. It's very individual.
Okay, let's try that memory tip for the main non-surgical options after basic topicals. Maybe AIB, aluminum, iontophoresis, botulin.
AIB, yeah, that's a neat way to remember the big three specialist options. Aluminum chloride optimization, iontophoresis, botulinum toxin. Good one.
So thinking about that patient with severe primary axillary hyperhidrosis who failed topical aluminum chloride, what's likely next?
Given its severe axillary and topicals failed, botulinum toxin injections would be a very common and effective next step offered by a dermatologist. It's licensed specifically for that indication.
All right, Botox for the pits. Okay, what about the long-term prognosis?
Generally, hyperhidrosis is seen as a chronic condition. It tends to stick around, though severity can wax and wane.
Doesn't just go away on its own, usually.
Not typically, although interestingly, for primary focal hyperhidrosis, it does sometimes seem to lessen a bit as people get older. But the prognosis really depends on severity and response to treatment. Many people get good control with the options available and see a big improvement in quality of life.
That's good to hear. Finally, what if it's not managed well? Complications.
Several potential issues. We've touched on the emotional side of distress, low confidence, social isolation. That's huge.
Yeah, the psychological impact.
Then there's the direct physical stuff. Skin getting macerated, soft, and broken down from being constantly wet.
Maceration, okay.
That wet environment is perfect for bugs, so fungal infections like athlete's foot or bacterial infections, which can also cause odor.
Malagor, yeah.
Right. And all of this, the wetness, the potential infections, the smell, can lead to severe embarrassment, affecting work and social life. Dermatitis, skin irritation is common too.
So managing it isn't just about comfort, it's about preventing these knock-on effects too.
Absolutely. Skin health, infection prevention, mental well-being, it's all linked.
Okay, so that's our deep dive into hyperhidrosis. We've gone through the definition, the types, primary, secondary, focal, generalized the causes, how it works, what else to think about, who gets it, the signs, investigations, the whole range of management from simple advice to surgery, prognosis, and complications.
Yeah, and the real takeaway seems to be nailing that primary versus secondary distinction as it dictates your whole pathway, and remembering the significant impact it has, both physically and mentally.
Definitely. A really solid overview based on that core information. It's quite something how a simple symptom like sweating can branch out into so many different causes and require such tailored management strategies, isn't it?
It really highlights the complexity behind seemingly simple presentations.
For more free MSRA revision resources, remember to check out freemsra.com. And for the full premium toolkit, head over to passthemsra.com.
And just a final thought to leave you with. Considering how much we've discussed the psychological impact, perhaps thinking about how we could integrate mental health support much earlier in the pathway for hyperhidrosis might be beneficial, maybe even before escalating to some specialist physical treatments. Could that change overall outcomes? Something to mull over.